others. All right. So I've been giving the subluxated lenses and loose zonules kind of course at CYRES for many years now. And in a subluxated lens, should we use a ring segment or should we use an ASIA anchor? And when is each of them indicated? Classically, we've always been taught with the subluxated lens, use a CTR and put a ring segment because that is readily available. So let's have a look how the video went. Put the volume off, please.
Should we use capsule hooks or simply drop anchor when
All right, let's have a look at the first case. So in this case, we used a femto system, which we have the catalyst, in order that we get a perfect capsulorhexis. In a subluxated case like this with extreme subluxation, even though you may be a very skilled surgeon, now and then you're going to trip up and the rhexis will go to the periphery. But when you have access to technology, this is the real use of technology and not just to do grade 1 and grade 2 cataracts and sell technology to patients. So when you have a femto system like this, we must learn how to use it for cases like this. Use capsule hooks and then just put the ring segment in the eye after suturing it to a single tenoproline, which you railroad out of the eye. So railroading out of the eye is a very simple and straightforward procedure. A 26 or 27 number needle goes in the eye and then the proline goes out of it. And that's the ring segment. Inflate the bag, put a CTR and the IOL in the bag. Now that case is over. Let's go to the next case. What if you have a poor rhexis with a small rim of capsule? What options do we have in this case? Now this is the same femto laser which misfired, and instead of doing a capsulorhexis has done multiple punctures in the superficial cortex. So despite it looks like a rhexis, it isn't. It's some kind of cortical perforations. So I had to use a rhexis forceps, and sure enough, as I predicted, rhexis ran out. And I've pulled the rhexis back in by breaking a few zonules, which is not the ideal situation. So yes, we have a rhexis, but no, we don't have enough capsular rim in order to put capsule hooks. So you need a device like this called an ASIA anchor. This video was made 3 years back. And so this was ASIA anchor generation 1. There's a generation 2 now, which is 3-dimensional like a paper clip. So this is a 2-dimensional device. And once again, simple, just suture it to the proline and railroad the suture out of the eye. Then just use irrigation aspiration and suck out the cortex. So that's the anchor, and the trailing legs of the anchor will imbricate the capsular rim like that and hold it. Then pass the needle twice through half thickness of sclera. This will give you an opportunity to lock the suture and suture it and put the knot inside the edge of the tunnel. So it will not extrude out. So once you tie it tight, then you have a nice capsular bag. And even this whole thing looks unstable, but it's really not. This patient is following up now 3.5 years. He's an 11-year-old boy. And so far everything seems to be good. So this was the end result of the case. Let's have a look at the next one. Can we use a single piece IOL as a CTR? This is what I showed 10 years ago and I thought it still has relevance. So I'm going to show it again. This is called the back to the wall technique, which we wrote up in Archives of Ophthalmology. So when you have an extreme subluxation like this, remember this was before the era of all this flanging and all this other stuff that you see today wasn't invented. And the only thing that people did in those days was a Sioni's ring. Ike Ahmed hadn't popularized his Ahmed segment either. So this was far, far ago, many years ago when I was a lot younger. This was 2.8 millimeter phacoemulsification because none of the systems had 2.2 then. And that's why we had this big, huge Utrata forceps that people will laugh at today. but you have to make a nice small rhexis. So the cornerstone of success in all these procedures to use pressure. If you see, the left hand is actually pushing the lens down, the iris depositor. So it gives you a little bit of counter pressure, and turn the rhexis around. So if you got a bad rhexis or if it's gone very peripheral, then you had it and you'll have to end up with some kind of other procedure, but you won't be able to do this one. Make 2 openings, suspend the lens with iris hooks. If you have capsule hooks, it is better, but we didn't have capsule hooks, at least not in Mumbai 12 years ago. So all these things are there now. So this is like a blast from the past. This is the old infinity system that we used to have. But it does the job. Let's go ahead a little bit. In goes the CTR. Now that you have a CTR, this is a single piece IOL, and you tie Prolene stitch right to the midpoint. So if you draw the line from where the stitch is, it should intersect the midpoint of the lens. Otherwise, your lens will be decentered. Then you pass this needle down the barrel of the injector and pull it out. So this way you can use the same 2.8 tunnel and inject the lens inside, rather than having to do a scleral tunnel and use a PMMA lens. So now you have needle attached to suture, attached to leading haptic. In goes the needle, and then it should come out of the eye about 2 millimeters behind. Yeah, there was no railroading, you're perfectly right. So all these things are all after 2010. In those days, you just pass the suture anyhow. Inject the lens. So today we would do things a little bit differently to this. We'd probably railroad the suture out of the eye, but you can still use a single piece lens in this manner. We use a femto laser to do the rhexis. But in the olden days, without all the modern gadgets and modern toys and having to pay crores of rupees to the companies, you can still do a fairly decent job. Once again, pass the suture twice, tie it tight. So now your leading haptic of the lens is used like a CTR and sits inside the bag. But of course you need, remember there's 2 things here that you didn't really see clearly in the video. First of all, the needle passed through the fornix of the capsule. The needle did not go above the capsule like a ring segment would. And so that's why the haptic can act as a CTR and stabilize the capsular bag. If your needle passes over the capsule and comes out very superficially about 1.5 millimeters or just behind the iris, the lens will pop out of the capsular bag. So that's the only thing, take home message. So you can try this out if you're adventurous. So that's the end of my talk. Thank you very much for having me.